So first off, these pictures show the Achilles tendon, which is made up of two different muscles. On the upper right, you have the gastrocnemius muscle and the soleus muscle, which is below and in front of the gastroc. Those two muscles form a combined or conjoined tendon. It's called the Achilles, and it attaches into the back of the heel. The muscle, the gastroc and the soleus, contract and it pulls the heel upward and it brings the front of the foot down as if you're pushing on a gas pedal or doing a calf raise. On the lower images, on that red area within the white Achilles tendon, that is an area where intra-substance or inside the Achilles tendon itself can become damaged and weakened and thickened. And it's an area where there's not as much blood flow as other parts of the tendon, and so it's very susceptible to becoming inflamed. Inflammation of a tendon is called tendonitis, and inflammation of the Achilles tendon is called Achilles tendonitis. The lower pictures are in the substance of the tendon, and then on the attachment in the very back of the heel is what you would call insertional Achilles tendonitis. Next slide, Don. So the causes of Achilles tendonitis, in general, it's inflammation of the tendon. So it's strain on the tendon. There's a little bit too much tension going through the tendon than it can handle, and it becomes inflamed. What causes that? In my opinion, the main thing is poor postural habits with core weakness and all that implies. And what I mean by that is how you stand and how you walk and move makes all the difference in the world. If you have good posture, then gravity is going to have a very neutral effect on you, and your skeleton should keep yourself upright. If your posture fails in any way or is weakened, then gravity is going to have a great load on you, and you need to withstand that load, and you need to use muscles and tendons to do that. Increases in walking or running can lead to aggravation of the tendon. Changing shoes with varying heels. So if you go from wearing high heels all the time to flats, that can cause inflammation of the tendon. Sudden increases in weight. And then the other thing that besides natural weight increases, a lot of people use vests and walk with weights. So they dramatically increase their body weight to improve strength. But it also comes at a cost because sometimes the tendons can't handle that strength that people put on their bodies. And then the lack of foot strength and dependence on shoes. So people generally rely on shoes to provide support or arch supports, and they never strengthen their foot. And a weak foot needs to be held together by muscles and tendons, and sometimes those tendons don't work as well. All right, next slide, Don. So the important thing to understand about the Achilles is it's controlled by two muscles, as we talked about, but those two muscles start in different places. One of the muscles attaches or originates above the knee, that's the gastroc, and the other one originates below the knee. So what affects the knee joint also affects the Achilles tendon, or said another way, what affects the knee joint also affects the ankle joint. It's like the song goes, ankle bone's connected to the shin bone's connected to the leg bone, and et cetera, et cetera. I won't sing anymore. But anything that affects the knee will affect the ankles. So ankle and knee positions are absolutely critical for normal function of the Achilles. All right, next slide. So what tones the hamstrings also tones the gastroc and also adds tension to the Achilles. This slide shows the direct impact of hip position on the hamstring and on the gastroc and soleus. So Achilles tendonitis essentially starts in the pelvis, because as the pelvis moves and shifts, it increases tone on the hamstring, which increases tone on the calf, which increases tension on the tendon, which can lead to pain after a while. Next slide. This is a really important slide to just sort of, you don't have to memorize it or study it, but I just want everybody to kind of be aware of how many muscles are involved with posture. From the neck to the spine to the hip flexors, which is that iliopsoas right in the middle, Gluteus maximus is just on your backside. Hamstrings, calf, gastroc and soleus to become the Achilles. That's all in the back. It's called that the posterior chain, and then you have everything on the front. Your quadriceps, your leg extensors, it's called the tibialis anterior, and even the neck flexors. You have to have balance between the back and the front. And when that balance is thrown off, you're going to have increased tension on one side. And that tension, especially when it's on the backside and the body is moving forward, is going to increase strain at the attachment points, specifically the back of the heel in our presentation. Next slide. And this slide shows the negative effects of anterior pelvic tilt. That middle slide shows the dashed line tilting forward. This is posture that we developed from years of sitting. I'm going to say it a little more specifically. When we send our children to school and we force those kids to sit in chairs while their bodies are growing, we develop tightness in the front of the pelvis or the front of the hips. And then when you stand up, the hip never really fully gets to neutral. You also need to be able to breathe properly to maintain a strong core, because it's the core that supports the pelvis. When you're not using your core to support the pelvis tilts forward. When the pelvis tilts forward, the hamstring, that green line in the back, that hamstring engages. It becomes elongated, and it resists being elongated, so it engages, and the hamstring becomes the stabilizer of the pelvis. When that happens, again, all tension is going to be shifted to areas away from the pelvis, and that's not a good thing for the feet. And on the far right slide, you can see what happens with the forward pelvic tilt. The front becomes short and tight, and the back becomes longer and taut, which just means toned. And then when the muscle is pulled elongated, it can't function as strong, so it's actually weaker. Next slide. So what are the treatment options? Most people have tried the first early on, ignore it and hope it goes away. Oh, it's just a little something, it'll probably get better. Try to maybe Advil through it or ice it or take a few days off. But if you didn't injure the Achilles, if it just sort of developed and it's not going away, it's because of the postural effects over many years. It led to more strain on the tendon. And it's not any one particular thing you did, but it's a combination of factors that ultimately led to the tendon hurting. So ignoring it and hoping it doesn't go away isn't the best treatment option. And of course, there's many non-surgical options, which is always our go-to, and then there's surgery. And the only time you'd probably ever really jump into surgery is when the tendon ruptures. And depending on who you are and the activities that you might want to get back to, I'll let Sam talk about that later, but surgery actually isn't always necessary for ruptured Achilles tendons. Next slide. So where do you begin? So the main goal, if you have tendonitis in the Achilles, and I like to refer to it as tensionitis, is to reduce tension in the Achilles by any and all means necessary. The other thing is we want to avoid positions of our body, as well as shoes and other activities that increase the discomfort. So you have to really be aware of what triggers the pain or what makes the pain a little bit worse, and you have to try to avoid doing that. We want to get stronger. We want to get stronger in the areas where we need to get stronger. Stronger posture, stronger core, stronger calf muscles, stronger feet. We need to move, and that's probably one of the best ways to get stronger. A few bullets above were the avoid position, shoes, and activities that increase discomfort. That doesn't mean don't be active. It doesn't mean sit on a couch and let everything pass. You moved your way into it. You want to move your way out of it. So that means finding activities and movements that won't increase the discomfort. So there are other options like sometimes biking instead of walking, or biking instead of running, or in a pool running. It's a little tough during a pandemic to get into the pool. But there's a lot of activities and exercises that we can do that keep us moving. And lastly, actively priming and recovering the muscles, the gastroc and soleus muscles, as well as the Achilles. And what this means is I like to think of our muscles as using an analogy like a lawnmower or something, where with a lawnmower or some type of equipment, you prime the engine, you get the oil going through it, the motor, then you start the motor up and you use it. We want to get blood flowing through the muscles that contract and relax and put tension through the Achilles tendon. If those muscles aren't primed, then the tension going through the Achilles is going to be significant. And likewise, after activity, if you don't allow those muscles to recover, the tension is just going to increase and increase. And then the Achilles is eventually going to become sore, and you may have a difficult time getting better quicker. Next slide, Don. So how do we reduce tension? And again, remember the muscles start both above and below the knee. So there are things to do with the knees extended and the knee flex. So bent knee, straight knee. Those are areas you got to focus on. Next slide. I do believe stretching is overrated. I think stretching absolutely has a role. But this slide shows how there are stretch receptors in the tendon itself that connect to the muscles. So some tendons, when they're stretched, actually activate the muscle. They cause the muscle to contract. So while you're feeling a stretch, there's no real stretch happening because the muscle is not elongating, and the tendon is being pulled even harder by the muscle so as to resist the stretch. There's something called neural detoning. One of the things I really like to do is to rub the tendon really with my finger back and forth for about 30 seconds briskly, right over where on the left-hand side it says Golgi tendon organ, lower down on the white tendon there. If you stimulate these nerve endings, these sensory receptors, what's going to happen is it's going to turn off the signals to the muscle so that the muscle will start to relax. And it's amazing how sometimes I'll test an ankle joint and I'll test how flexible the calf and the Achilles is, and it's as tight as can be. And I'll just do some rubbing on the tendon, no muscle work whatsoever for 30 seconds, and I'll retest it. And I usually have a significant increase in the ability for the muscle and the tendon to lengthen. Isometric stretching is a stretch where the foot and the ankle don't shift position, but you increase the amount of strain to the muscle. So basically nothing moves, but you're pushing the foot down and you're pulling against the foot so that you're loading the muscle. That's an excellent way to kind of prepare the tendon and muscle to be used. And eccentric strength is lengthening of the tendon. Think of dropping slowly off a stair. A lot of people use that as a stretching exercise. I think the best forms of stretching are ones that involve strengthening the muscles. So isometric strengthening and stretching and eccentric strengthening and stretching are better than just leaning against a wall or just hanging off a stair and doing nothing. Next slide. How do we reduce tightness or tension or tone? I use tightness, tension, and tone as interchangeable words. Again, stretching increases tension, so stretching does not reduce tightness. Rolling, foam rolling, massage is going to increase blood flow through the muscles, going to help both prime the muscles prior to activity and as well as help them recover after activity and help them relax even more. Next. These are different ways to reduce inflammation. We have somebody rolling on a frozen water bottle at the top, and then the bottom shows contrast baths. So ice and heat, and a good protocol is 5 minutes in an ice bath, 5 minutes in a warm water bath, and 5 minutes in an ice bath again. What this does is ice was going to help with pain, but the contrast going from cold to warm to cold, it's going to get blood flowing in and out, and it's going to help increase blood flow to the tendon itself, which, as you're going to learn in a little bit, is integral to these tendons healing. There are pills and anti-inflammatories you can take. Again, these are pain reducers. They're not going to help heal the tendon up. You have to combine anti-inflammatory action with actual activities that are going to specifically be focused on reducing the tension and strain on the tendon and muscles. This is two forms of stretching. The top was a night splint. It's a passive stretch. So you just sit there and the splint pushes the foot back. or it doesn't help. It doesn't allow it to flop forward. And the bottom one is a static stretch where you're just pulling the foot back. I'm not a huge fan of these, but some people get pain relief, and if these are helpful and they help reduce symptoms, have at it. I think they're fine. They're not harmful, but they're just not as helpful as Dr. Google might explain them to be. And heel lifts are commonly used, and you'll see this all the time. Now, the heel lift does not reduce tightness. It actually increases tightness, because when you elevate the heel, that lower right picture, you're actually shortening the calf muscle. And the shorter the calf muscle gets, the tighter it's going to get. Think of a bodybuilder with a really big bicep. They can't even straighten their elbows out because the bicep is so big and contracted. When you elevate that heel, the muscle is going to contract and you're going to tighten the ankle. Now, heel lifts help. They can help reduce symptoms and pain, not because of their ability to reduce tightness, but because they're putting the ankle in a better position. And when the body moves forward over that foot, it lessens the tension at the attachment point of the Achilles tendon. So there's less tension on the back of the heel when you're moving forward with a heel lift, but you're not reducing tightness. And then there's other ways to stabilize the foot and reduce pressure. So in really acute situations where somebody's tendon is very inflamed and I'm worried about it tearing or rupturing, or somebody's limping or it's swollen, we'll oftentimes put them in a walking boot, because if you don't allow the ankle to bend when you're walking, then you're not really putting very much strain at all on the tendon, and you're going to allow it to calm down. And when a tendon is all fired up and inflamed and aggravated like that, you have to either not walk at all or walk with immobilization. The upper left is just a splint, a stirrup, sort of like an ankle sprain splint, and sometimes we go from walking boot to ankle brace to shoes. And orthotics are also something that can be helpful. That middle picture with the bent lines, I think the important thing with that is when somebody's heels turn out or their ankles turn in, the Achilles tendon is naturally shortened. And again, kind of like with the heel lift, everything gets contracted. If you're living with shortened Achilles tendons, it tends to put a lot of extra strain on there. So orthotics are going to realign the heel and allow you to have a more normal length tendon over time. So orthotics, in my opinion, with orthotics is we're trying to assist posture, not support the arch. I think it's really important to have strong feet. And then again, stabilizing the foot and reducing pressure. This is a classic sort of historical treatments, inserts and supportive shoes. And I like these slides just because if they help, if there's a shoe that feels more comfortable, if there's an insert that feels more comfortable, absolutely use it. Use whatever makes it feel better in the moment, but we don't want to rely on these things to help fix us in the long term, because these will not fix the problems. They'll help symptoms, but they won't fix problems. Physical therapy is another modality we often use to help with postural realignment, strengthening, mobilization of joints. These tools here are scraping tools. The middle one shows something called Graston. It's a metal bladed edge. Physical therapists and chiropractors use these all the time. And then I have some other items that are sold to people's houses. On the lower left, we have the edge tool. The upper left is the sidekick swerve, and the lower right is the gua sha tool. These are all under $100, and they can help with that neural detoning by scraping the muscle and the tendon, and just helping with blood flow and just helping to loosen everything up. But these are good tools. I would definitely suggest having instruction and guidance before just going to town on these. And if you are to use something like that, you certainly don't want to do it every day, because when you're doing this type of scraping activity, you do need the tissues to recover. So you want to at least give it 2 days between these types of treatments.
Well, thank you, Dr. Feldman. Those are some great tips there. And wow. Okay, half of our time is done here. Thank you.
Sorry, guys.
we have all night here. I'm going to be brief here. I'm going to talk a little bit about the imaging for the Achilles tendon. Many of you that come into the office, the first thing we do is get an X-ray, and a lot of times people ask, well, you're looking at my Achilles, which everyone knows is a tendon. Tendons don't show up on x-ray. Why would we get an x-ray of the foot? The main reason is some people that have Achilles tendonitis at the insertion point, they can actually have a bone spur that can be problematic. Very rarely, but occasionally there can be pulling on this in such an extent that it could cause a little bit of a fracture at that bone spur. That's one of the reasons. Also, we like to look at the overall architecture of your foot to see, do you have a relatively high arched foot, a relatively low arched foot, or if there's any other types of arthritis in your foot. Another thing that Dr. Kellner is going to talk a little bit more about, do you have a bump on the back? Is there a spur, or is there kind of an enlargement here in the back that's causing the area to protrude, in not just the Achilles itself, but this is something called a Haglund's, which we talk very commonly along with Achilles tendonitis, and we're going to cover both of those subjects tonight. And that's another reason we would get an x-ray to look if there's anything else going on that we're not really seeing. And then very quickly, once we try some treatment, for example, you would come in the first treatment, all of us get x-rays to start, and then we might try some treatment. And if you're not responding, or even if you are responding, but mostly if you're not, we would quickly switch to an ultrasound. And we've been very happy to have an ultrasound the last couple of years in the office. And it's just made it a lot easier for us to look at the Achilles, because when you look at the spur, that's all you see. You don't see any of the tendon. But when you look at the Achilles, you can see the Achilles as it comes down, and you can look at what would be kind of a normal fiber pattern. And then you can look at a different fiber pattern where you can see little areas of darkness or black. We always say white and gray is okay, but black is bad. And if we see an area of black, there's potentially some type of an injury at the insertion. This is kind of the tendon coming down and inserting into the heel. There's different flow patterns that we can look at with the ultrasound as well. And what we're looking at is we're trying to pinpoint a certain area of injury. And that's really important, because let's say the entire Achilles looks great, but there's this one focal black area in the Achilles that may warrant doing what Dr. Savvy is going to talk about, is like an amnio injection or some other type of injection right in that area where there's a focal point of injury after we try the other types of treatments. That's where the ultrasound exam comes in and is helpful. When we look kind of as if you're cutting it right in half, the Achilles, you can look at the normal fibers, and then you kind of see different types of fibers that might be a different color. It could be around the peritoneum, which is the area around the tendon. It could be other areas that are discolored, okay, as well. Here's a couple of other examples. An example of thickening in this little black area probably is a tear in the Achilles tendon. So these little micro tears, or these smaller tears, this isn't a through and through tear. This is an area of thickening with a little tear in the center. Here you can see areas around the tendon, like the peritoneum around the tendon can be inflamed. The tendon looks fine, but it's really painful. And once again, this is an area that sometimes we can infiltrate some type of medicine in there, or do other type of advanced treatment to take care of that. And then if that still doesn't help us to see what's going on, we could get an MRI. And we don't do too many MRIs at this juncture unless we're considering surgery, or if we're considering there's a rupture and we can't determine that without an MRI. But this is an example that Dr. Feldman referred to. If there is a complete rupture in there, then the treatment is different. It could be a surgical repair. It could be putting you in a cast with your foot kind of bent down to help that reapproximate. And that's one of the reasons for an MRI. Also, if we want to look at the extent of the injury, if there's thickening in the Achilles, partial tear, or a tear at the area of the insertion, or an area of inflammation behind. Sometimes the tendon itself is fine, but I guess it's not behind, but it's in front of the tendon. There could be an area of inflammation, like a bursitis, or another type of a problem in there. Here's an example. You can see normal tendons kind of look normally black on the MRI. And then when you look at an area, you could see the area around the tendon, the peritoneum, there's a little bit of inflammation around there. That's the benefit of an MRI. We don't order too many MRIs, but just to give you kind of a couple of examples of a kind of a normal tendon looks normally black. And then areas of bursitis, or that Haglund's, that little bump of bone right there. So these are some of the reasons we do some advanced imaging, and then that would lead us to some of these other treatments. And that's what Dr. Savvy is going to talk about next. Shockwave PRP, and amnio. And so, Ben, let me just spotlight your picture here.
So thanks everybody for coming. Thanks, Dr. Feldman, for munching up half our time here. I can see why you run behind in clinic. Keep yourself muted. You're not allowed to respond. So the stuff I want to talk about, it all falls into this category of regenerative medicine. So if you do a quick Google search of regenerative medicine, I love this little DNA man over here on the left. I've used him before, but the Wikipedia answer is the process of replacing, engineering, or regenerating human or animal cells, tissues, or organs to restore or establish normal function. So we can't use any of these things to make you like a superhuman or anything, or like a superhero. But what we can do is try to stimulate your body through a couple different processes to use your normal tissues to activate that sort of healing mechanism to get you better. And there are instances where we'll sometimes use those human-derived products that help you to stimulate that regenerative process. We're good there, Don. So the first thing I want to talk about is something called shockwave therapy. I am a huge proponent of shockwave therapy. If you ever get shockwave therapy from me, one of my more common things is I don't shockwave anyone more aggressively than I shockwave myself. I shockwave myself on a regular basis for a couple different things, couple Achilles tendon injuries actually. But effectively what shockwave therapy is it's our way to hijack a healing system, a healing pathway, and mainly a blood flow creating pathway in your tissue. So what we're doing is we're just turning your body on to what is usually an old injury that your body's not reacting to anymore. And we're turning it into an acute injury stimulant. So your body goes there and heals it. So there's a couple different ways to generate a shockwave. The two most common that you find are radial shockwaves, which John's highlighting there, Dr. Pelto highlighting there. Effectively, that's a little bullet in a chamber on that device, the handpiece down below. And that little bullet oscillates back and forth. It hits the tip of the applicator and it creates a pressure wave. That pressure wave has areas of high pressure, followed subsequently by areas of low pressure as those, picture like a slinky, those tissues kind of moving back and forth. And what that does is it generates a signal to the cells in the tissue that they otherwise wouldn't receive unless they were being injured from a trauma or a fall or getting hit with a soccer ball or whatever it may be. And what that's going to do is make them wake up and go, whoa, geez, we got to go react to this. Another way to generate shockwaves is with a focus shockwave device. That's sort of, in a way, kind of picture your high school physics classes with lenses and light and bending light. It kind of is like that. We use a piezoelectric pulse generator, and that's able to focus the shock impact at a deeper level in your tissue. So I like to compare these two things. The radial shockwave is a little bit like doing a belly flop, and the focus shockwave is a little bit like watching that Olympic diver hit the water. So both are equally effective ways to hit the water, but one is going to get you a little deeper, and the other is going to keep you a little more towards the surface. And so that response I was talking about is mechanotransduction. So your cells are going to take that mechanical signal and they're going to translate it into production of proteins and stems and mesenchymal stem cells, which generate healing. They're going to create capillary ingrowth into that area to increase blood flow, this whole pathway. And luckily for you, when we do this, or for me, when I do it to myself, there's a chemical called substance P that is basically burned up when we shockwave you. And imagine it's like a little, it's like a phone card, if anybody ever uses those anymore. It's a little phone calling card that allows you to transmit pain signal to the brain, and we kind of burn it up. We use all your anytime minutes to transmit pain, and then after that, you're feeling pretty good after shockwave. So in terms of when should you consider shockwave, for me, it's a first line treatment. It really depends on the patient. A lot of my college athletes and my serious runners, they will opt for shockwave right away because they have tried a lot of the home remedies first. They've tried their foam rolling, they've tried their stretching, they've tried their contrast bath, and they're looking to make this improve a little faster. Shockwave is an excellent way to get things to heal faster. So a big fan of that. What are my problems with it? They are few and far between. My main problem is with the insurance company. In Europe, this is covered by almost every socialized medicine system in Europe because they care about getting their patients better faster and as cheaply as possible. And I'll stay off my soapbox, but that's not the type of system we have in the United States. So there is a small cost that comes with this treatment, but it is worth every penny in my mind. So I like to use a lawn care. Oh, go back one more. So I like to use a lawn care analogy when talking about these advanced medicine treatments. But the lawn care analogy for this is kind of, you have that dead patch in your lawn. What we're doing with Shockwave is we're going to use your lawn's natural healing pathways to try to fix that dead patch. So we're going to aerate it. We're going to make sure that it gets adequate sunlight. We're going to make sure that it's getting enough water. And we're going to expect that the rest of the lawn is going to kind of fill in that patch and get it to heal the way it's supposed to. All right, so we'll go to the next one. Next one is PRP. I will give you the Cliff Note version of PRP, which is effectively we are going to draw a little bit of your blood. We're going to spin it down in a centrifuge, and then we're going to re-inject it. So how it works is we're basically concentrating the right stuff. We're going to inject that right stuff into an area of injury. When you should consider it is, again, patient dependent. I have some people who have long-standing injuries. It's been a year, 2 years. They've seen other people. They've tried Shockwave, which is on the cheaper side, and now we're looking for what the next step is. And if they're young and healthy, then PRP is a great option because they probably have the right stuff. As you get older, you start to use up some of your mesenchymal stem cells, and you're not able to really create all that same healing potential that you otherwise might have had when you were 18, 20, 30 years old. And once you start to run out of that stuff, it's really hard for us to capture that in a blood draw and then hope that we inject it into the right spot. Now, my problems with it are certainly more than Shockwave, but it's still an excellent treatment modality. There's a lot of mixed literature on it. I think a lot of that has to do with it being very operator dependent. So the person performing the injection, it also has to do a lot with the patients. So if you pick an older patient population, you're less likely to have as much success with PRP because there's just not as much good stuff floating around in your blood. And I also think it has to do a lot with inaccurate injections. You spin down about 30 cc's of blood and you get about 3 cc's of liquid gold that you're going to inject. And if you're not doing that with ultrasound guidance, then the odds of you hitting that tissue where you need to are slimmer. So in our office, we use ultrasound guidance for any of these injections where we're making sure that we're injecting it directly into the tissues that need it the most. So for me, the lawn care analogy here is a little bit like taking what you assume is healthy patch of your lawn from an area that looks pretty good, and you're going to sort of carve that area out, and you're going to transplant that right into the dead patch in your lawn and hope that it takes and grows the way that it's supposed to. Oftentimes, you still want to stimulate it and get it to do what you want to. We'll go to the next one here. And the last one is the amniotic tissue injections. So this is very, very similar to PRP in many ways, in that it's an injection that's given into the injured tissues. Where it comes from is the placenta from C-section birth. So it's all of this amazing pluripotent stem cell mesenchymal material and extracellular matrix that your body uses as a scaffold to try to heal. So there are people who are way smarter than us that came up with this technology and have been using it for a long time, and it's been adapted into the sports medicine world. So how it works is we're taking an injection of what we know is 100% the right stuff, and we're injecting that into the injured tissue to try to get your body to respond and heal that area. When you should consider it is another big depends. I use it for people who are recalcitrant to almost everything else. Obviously, this is coming from live C-section birth, so there's a cost that comes with that, screening donors and things like that, and preserving that and getting it on the shelf and getting it delivered to us. So there's some cost to that. It's certainly the $3 sign on Google compared to the $1 sign, but it's one of those like rocket fuels for healing. My problems with this are some of the same as PRP. There's way less mixed literature, but you still have the same issues with inaccurate injections from people not using ultrasound, and you have doctors who are just either not doing it in the right way or not doing it in the right spots, and that's trouble. So that can create some issues, but we do it under ultrasound guidance. So we take this half a cc or 1 cc of liquid gold and inject it into the right spot. So for me, this lawn care analogy is going to Foxborough Stadium and cutting out a swatch of the field of the most professionally manicured turf and transplanting that right into the middle of your lawn instead of banking on the Miracle Grow or anything else. You're just going to take a piece right out of Patriot Stadium and drop it right in your lawn. And this is just a little ultrasound view of doing that injection. Our ultrasound is so good that I could teach a monkey how to do these injections the right way. And it is always fun to watch patients totally understand what we're doing as we're injecting them. So just sort of a rundown of what that might look like.
Very good. Dr. Saviat, there was a question. Is there any evidence that a second round, a year or more after the first round of shockwave therapy, further reduces Achilles pain?
Yeah, absolutely. So one of the things that I describe shockwave as is basically we're trying to dig you out of a hole. And sometimes we just didn't quite get you out of the hole the first time through. So a second round of shockwave can continue your progress out of there. Oftentimes there are folks who make a fair amount of progress. They're able to be more active, but they still have those underlying postural issues. So they may have never cured, we may have fixed their symptom. We pumped up their tire, but they never got their car realigned when they needed to fix the posture too. Otherwise, sometimes we're just treating symptoms instead of treating the cause. So yes, there is plenty of evidence that demonstrates the second round after the fact is good or can be good.
Thank you, Dr. Saviat. And now we have Dr. Kellner here. He's going to talk a little bit about the surgical treatment.
Hi, everybody. I know we're trying to get down on time here, so I'll try to be quick but thorough on what our surgical options are. Basically, what it comes down to is you've been through everything, all of the physical therapy and bracing, stretching, neural detoning, fixing your postural habits and such, but you're still having pain and it's not going away. We do keep our surgical options on reserve for the small percentage of people that just don't get better. So primarily, I'll just talk about what a Haglund's resection is. When we say Haglund's deformity, that's just kind of that bump in the back of the heel bone, and that can irritate the tendon. And why it's more than just removal of the bump, because there's also Achilles tendon repair involved with that procedure. The procedures I have listed as secondary are things we typically do just either as an adjunct procedure with our Haglund's repair, or sometimes done in isolation. All right, next slide. So here on the left side, we just have our preoperative X-rays of someone. They have heel spurring directly behind the heel, and with calcification inside the tendon itself. They also have kind of a bump on the top and back side of the heel. That's your Haglund's deformity. And then looking postoperatively, what's going on? How we basically remove all of that unhealthy calcified tissue, and just make it more comfortable and taking away that painfully inflamed tendon. The issue here with this type of procedure is that Achilles tendon is in your way, essentially, of getting to those bone spurs and calcifications. So when you access the area through incision in the back of the heel, you actually have to go through the Achilles tendon, detach it to get to those areas, and then afterwards reattach the Achilles tendon with some specialized hardware. We use screws or it's basically a tendon implant screw and specialized fiber tape to hold it back together. So that's why it's not just a simple bump removal. Next slide. In some cases, a gastrocnemius recession is employed with the Haglund's repair, or sometimes done in isolation for other things. Basically looking at the gastrocnemius muscle belly, there's a junction where it starts to become tendon. And in that higher up portion there, where that instrument is going across, is the area of the, it's called an aponeurosis, which is like a fibrous ligament of as the muscle belly becomes tendon. And that is the area that we just basically release through either an open procedure, which is a small incision, or we can also do it by means of an endoscope, which is a little camera and a little blade through portals on both sides of the calf, and we can release that area, and that reduces the chronic contracture and tension, and helps the distal portion of the Achilles tendon not be so tight and inflamed. Next slide. Another procedure sometimes considered is what's called an FHL transfer. When I say FHL, that stands for flexor hallucis longus, and that's your long flexor tendon, as Dr. Pelto is showing you there. It starts from up in the back of the calf and courses behind the ankle and stabilizes your big toe, allowing it to purchase on the ground. For some cases of chronic weakness where the Achilles tendon isn't functioning appropriately and you're having difficulty with, just kind of your propulsion and in your gait, or just doing a simple calf raise, and you have weakness in that area, we can actually harvest that tendon kind of right where that FHL arrow is, right through our original procedure if we're working back there. We can release it there, and in the bottom picture you can see that it's being transferred into the heel bone itself with what's called an interference screw. That's just a screw to hold it inside the bone, and that gives power to the Achilles tendon. I do like to comment that the stability of your hallux, or your big toe, is not sacrificed completely in this procedure. In the sketch diagram, there's what's called the Henry's knot, where there's an area of this tendon attaching to another tendon that goes to all of your smaller toes, and that allows the tendon to still function appropriately. And you also have what's called intrinsic muscles of the foot, which aid in stabilizing your big toe as well. So it's not too much of a sacrifice, and it is often very helpful for assisting the Achilles tendon when you do this procedure. Next, we're looking at the topaz procedure. Basically, this can be done either open, whereas we're already doing the Haglund's resection and you're directly visualizing the Achilles tendon, whether it's very thickened and nodular and scarred, or you can do it as just an isolated procedure, as shown on the left there where the grid is drawn out. There's a bunch of little poke holes are made through the skin, and a wand is introduced through each poke hole right into the tendon body, right into the area that's most painful or most nodular and thickened, and it introduces what's called a radiofrequency ablation, which is a low heat energy, and it's also propagated with a little bit of water or saline that's flowing through the wand tip, and it basically provides an energy that converts a chronic inflammatory condition to an acute inflammatory condition and stimulates the body to repair those areas and break down scarred tissue. Next slide. And then the last one here is what's called the 10X procedure. This is also a minimally invasive procedure done under ultrasound guidance. Basically, on the picture on the left, and that person's left hand is the ultrasound probe itself, and in his right hand is the 10X device where it's a little wand with an 18 gauge needle. It's a thick needle, and it is an ultrasonic debrider, which can cut through and debride unhealthy tissue, and it does not affect the healthy tissue. In the animated picture on the right, you can see it with the Achilles tendon is above the debrider, and below is the bone, and in between that, in that area, that's the unhealthy tissue that it's capable of debriding, and it sucks it out as you do it. So it's a pretty cool procedure and very quick recovery. Overall, looking at the bigger picture with the Haglund's section, this is an animated version of what the Achilles repair will look like after all the bone spurs and calcified unhealthy tissue is removed. I always like to focus at the beginning on the incision healing. You do not want to have any infections or delayed wound healing, incisional healing complications. So typically you're seen at 2 weeks, and at that point the sutures are removed. Going forward, looking at Achilles tendon healing, we need to ensure that the Achilles tendon appropriately reattaches to the heel bone itself. That process will require immobilization and non-weight bearing for a minimum of 3 weeks, often 4 weeks, to ensure that you don't have any kind of tendon re-rupturing off the bone, because that can be a mess. And it's a very secure repair, and we feel very good about it, but usually about 4 weeks. After that, it's usually transitioned to some kind of walking boot, perhaps with a heel lift, and that is removed over a period of a week or two. Physical therapy often referred to, because that can be very helpful in just restoring range of motion. And you do want to get early range of motion, pretty much early, as soon as possible, without risk of the re-rupturing the tendon, as we want the sort of minimize scarring and obtain that full range of motion again. For full return to activity, I say you're walking in a sneaker, hopefully by the 2-month mark on average, and then return to running in sports at about the 3 months. So it is a bit of downtime that you have to consider, and plan your life around this procedure if it is necessary.
Great. Thank you, Dr. Kellner. We're finishing up here. I know we said we'd try to keep it under an hour here. If you have any other questions, you can type them in the chat box right now. Dr. Feldman, how can you prevent Achilles tendonitis? Is there any way to really prevent it?
I think the biggest thing is just to pay attention to the little things in life. Like if you're starting an exercise program and you haven't really been doing very much, you don't want to jump full in and expose the body to a lot of stress and strain that it hasn't been used to. So building slowly. We walk before we run for a reason. I'm not saying if people want to start running that they have to walk first, but if you want to start running, I like running. I like it a lot, but just start running slowly, and don't go out for a 30 or 40-minute run for the first time you're running in years or months or ever. Start with just 10 minutes at a time. There's a concept called tissue tolerance that's really important to understand. The tissues and the Achilles tendons, muscles, ligaments, bone, those are all types of tissues. They can tolerate a certain amount of strain and stress. And if your tissues are used to handling a lot of strain and stress, then you can do a lot with them. If your tissues are not used to handling a lot of strain and stress, it's going to take time to build that. If you have been a lifelong active person, it's going to take less time. If you have not been a very active person for many years, or if you're not all that healthy, it's going to take a long time. In our society, we're sort of a quick fix, impulsive society. We want what we want when we want it. Having a teenage daughter, I can, I live that. But it's me too. And it takes years really to to safely develop enough tissue tolerance to, say, handle a marathon. Now, that doesn't mean you can't go out and run a marathon within 3 months of training. There's some people that run marathons without ever doing any running throughout the year, and they go out and run a marathon. That's not really the best way to do it, and then you're just pretty much asking for trouble. So if you want to become an active person and you're not just after this sort of goal, checking something off the box, a life goal, and you want to just, sustain activity, it's just really important to develop good habits of movement and slowly build and not overstress and pay attention to the little things.
Yeah, perfect. And how, I think we've kind of addressed some of these other two already. How do you prevent a tear when you've had continued aching? Is aching the same as a tear in your opinion? I think we've kind of addressed that, haven't we? I don't think it's the same.
So we use like doctor speak, like bone spurs and tears and ruptures and splits. And, tearing is just advanced tendonitis. If you continue to pull on a rope and you subject it to a lot of strain, some of those fibers are going to split a little bit because there's too much strain on there. That's considered a tear. If the rope snaps, that's a rupture. So a tear is just a certain level of scarring or unhealthy tendon that develops within the actual tendon. When you see thickening or swelling of the tendon, you pretty much have to assume it's a tear. And again, tears are not ruptures. Tears can be healed through the modalities we discussed today, or they can be healed enough to withstand running and other activities, remain thickened, remain somewhat weaker. But if you do all the little things to keep your posture good and the muscles strong and your joints mobile, then you'll live a very active, healthy life without really having pain and symptoms. Just might be more susceptible to it if you forget what got you better in the first place.
Yeah. Dr. Saviat, can chronic Achilles tendonitis be resolved? Is there hope for everyone on this call?
Oh, yeah, absolutely. I mean, there are some people who have run the gamut physical therapy and they think they've done everything in the world, and then they come into the office and we find out that what they were doing in physical therapy was they'd sit there for 5 minutes. They give a year of their life to physical therapy, and what they were doing in physical therapy was sitting there for 5 minutes with a warm pack on their Achilles. Then they would ride the bike for 10 minutes, and then the physical therapist would do a little bit of massage, and then they'd say, "Okay, you're great. Go hit the bike for 10 more minutes, and then hit an ice pack, and you're done." That's an hour of your life twice a week for a year. People will do that, and they think they have chronic Achilles tendonitis, and what they have is a poorly managed Achilles tendonitis that is in the chronic state because they didn't get enough done to it. So those folks tend to get the kitchen sink from me. So anytime somebody comes in with this and it's been more than 6 months, we get a full rundown of what you've tried. And by icing, I want to know exactly how you ice. Were you just putting a bag of peas behind it, or were you just doing a block of ice that you use to keep your cooler cold? Because that's not going to do anything. If you were doing contrast baths, I'll believe you that you were doing some real icing. If you did physical therapy and you did some Graston therapy and some foam rolling, then I think you got a fair shot at maybe having to go to the next step, which is the shockwave or the TRT or the amnio. And then there's people who've tried that stuff, and we move on to surgical interventions, and there's a lot of ground to be gained there as well. So yeah, while I think the vast majority of the population, we're talking 999 times out of 1,000, we're going to be able to treat your chronic Achilles tendonitis.
Yeah, thank you. There's a couple of other, here's, if anyone has any questions, you can call the office, but there's a couple more questions that people gave us here. Have any of you guys heard about nitroglycerin patches that used to be used? Maybe I haven't heard of them. Ben, have you?
Yeah, I absolutely have. Who'd that question come from? That's a great question.
Andrew's here.
So it is not something that I have done yet because it's entirely off-label. However, I found the research that was done on it for lateral epicondylitis, so that's tennis elbow. And you basically take a nitroglycerin patch, which is what they use for people who are having like chronic angina. And those people, you slap that little nitroglycerin patch on there, and it's going to create vasodilation and basically increased blood flow to the area. So yes, we can use it, but it's a little bit off-label. Can make you a little dizzy. I'm willing to try it if people would like to try it, but there are some possible consequences to it. Pretty minimal. Okay. Very excited about that question, though.
It's a psyched question. Okay, so seek us out. We'll help you afterwards, for the one that sent that to me. Another question, do flat feet cause this problem, and will flat feet impede the healing process? Probably Dr. Feldman, you can speak to that a little bit.
Well, that was that slide we showed initially with the heels kind of angled out and the arches collapsed in. Flat feet so a flat foot is a foot that doesn't have an arch. An arch is necessary for the foot to function with normal mechanics. When your foot flattens out, it becomes an unstable foot. And when your body is moving over the foot, the bend point, instead of being in the ankle, comes in the foot. And then the Achilles and the calf muscles they're never lengthened the way they should be. So people with flat feet generally tend to have tight Achilles tendon and calf muscles because for the reasons I just mentioned. So it predisposes someone to Achilles tendonitis. But I would say any extreme does. I think somebody with really high arches also is predisposed to Achilles tendonitis. We want to be pretty much in the middle of the bell curve if you want to avoid specific aches and pains, because if you're on either end of the extreme, whether it's really flat feet or really high arched feet, you're going to be susceptible to Achilles tendonitis or plantar fasciitis. I would say the high arched foot is more susceptible to the Achilles tendonitis than the plantar fasciitis, but I think either flat foot or high arches they're tough. They're tough to deal with.
Thank you. And the one final question as we finish up here. If you have 4 or less than 10 degrees of ankle joint dorsiflexion, Dr. Feldman, what's the best way to increase the range of motion without aggravating the Achilles? You talked about it, but just finish up with that.
It's really important to find out why you have less than the optimal amount. 10 degrees is sort of the sweet spot number. You should be able to bend your ankle more than 10 degrees for normal function. But why do you have less? Sometimes there's a bone spur in the front of the ankle that doesn't allow the ankle to bend appropriately. Sometimes the tendons and muscles are so tight. So if you don't have a bone spur and the anatomy is fairly normal, foam rolling and isometric stretching and eccentric stretching are probably the best ways. Along with that, brushing of the back of the tendon to reduce the neural tone, to reduce the stretch reflex. Because again, a lot of people try to stretch, and as soon as they activate that stretch receptor, the muscle clamps down, and you actually don't get anything elongating.
Well, great. Well,
Did that answer that? I don't know.
I hope that answered the question there. I want to thank all you guys for all the participation. Hey guys, thank you for watching Healthy Living. You're going to find a few links here I'd like you to click. One is to subscribe to this channel on YouTube. Also, you can learn more. There are some videos here you can see.